Walaikum assalam, doctor.
Okay, can we start?
We have around 82 participants. I think you can start.
All right. Bismillah ar-Rahman ar-Rahim. Today we're going to talk about a very important subject, which is cerebrovascular disease, the types of cerebrovascular disease and the approach to that. Now, a little comment before we start that the lectures are a guide for study. They are not a notebook and they are not a textbook. So they just highlight the important things that you need to dig into the references. And the difference between studying in a university and studying in a grade school, that there are two differences. Number one, that the university student digs the information for himself. And the second difference is that universities are supposed to generate information. So that's why they do research. So we will talk today about cerebrovascular disease. And of course, cerebrovascular disease, we need to learn about the blood supply to the brain. The blood supply to the brain starts from the base of the brain, and it is divided into anterior and posterior. The anterior part comes from the carotid, and the posterior part comes from the vertebrates. And there is, at the base of the brain, anastomosis at the level of the circle of Willis. Not everybody has a complete circle of Willis that connects all the blood supply to the brain. Sometimes one or more of the communicating arteries is either missing or hypoplastic. Now, the brain is about 1 or 2% of the total body weight, but it receives 15% of the total body weight, total blood supply of the body, and it consumes about 20% of the total oxygen that is consumed by the whole body. And the blood supply is auto-regulated, which means that the blood vessels can dilate in the phase of decreasing blood pressure or mean arterial pressure in order to allow more blood to come to the brain with a little force. And it will constrict if the blood pressure goes high. This is the auto-regulation. And there are several vascular territories. And as we can see here, these are the vascular territories of the anterior cerebral artery, which is mainly on the mesial side of the anterior part of the hemispheres. There is the largest, which is the middle cerebral artery, which is the lateral part of both hemispheres. And there is the posterior cerebral artery, which is the inferior part of the hemispheres, and the occipital region, which serves vision. Cerebrovascular disease, we divide it by the mechanism by which it happens. It either happens by occlusion of the blood vessels that supply the brain, either the carotids or the branches of the carotids, the middle cerebral, and so on. So the occlusion may be by in situ thrombosis, such as happens in what happens in atherosclerosis of the middle cerebral artery and so on. And there is embolic occlusion, which happens from a clot that travels, for example, from the heart. We have the hemorrhagic cerebrovascular disease. Either the blood will get out of the circulation into the parenchyma of the brain, we call that intracerebral hemorrhage, or it can go out in the subarachnoid spaces covering the brain. We call that subarachnoid hemorrhage. And there are other vascular diseases such as lacunar infarcts, slit hemorrhages, and acute hypertensive encephalopathy. We'll talk about them later on. Now, cerebrovascular disease denotes an abnormality in the brain that is caused by a pathologic process of blood supply to the brain, and it can be either thrombosis or embolism and hemorrhage, and cerebral and cerebellar hemorrhages happen in about 10 to 15%, while subarachnoid hemorrhage, fortunately, it's not very common. It's about only 5%. Stroke, it's a clinical syndrome that consists of a rapidly developing clinical signs of focal or global function of the brain. Now, in case of coma, where there is interruption of blood supply to the brainstem, we will talk about coma in the next lecture. The disturbance of cerebral function lasting more than 24 hours, and it may lead to death with no apparent cause other than a vascular origin. This is the definition that is given by the World Health Organization for stroke. It is the second leading cause of death in the world, and the incidence increases with age, and it is more in males than in females. Common sites of brain involved in the stroke include the internal capsule, the brainstem, the cerebral cortex, basal ganglia, and cerebellum. Now, a few words about transient ischemic attack. Transient ischemic attack is a transient episode of neurologic dysfunction. For a short while, the person may experience something exactly like a stroke, caused by a focal brain dysfunction or spinal cord or retinal ischemia. Without acute infarction, it doesn't lead to tissue damage, but it causes dysfunction. It is a warning. It is equivalent to angina pectoris in the heart. It doesn't cause infarction in the heart, but it gives us the idea that there is a compromised blood supply. Stroke is classified, as I mentioned, into transient ischemic attack or into an ischemic stroke, and transient ischemic stroke causes damage that results in from occlusion of a vessel, and it persists. So the ischemic stroke is the commonest form of stroke, while hemorrhagic stroke is less common. And as we can see, sorry about that. Focal cerebral ischemia is an occlusion leading to focal ischemia, then to infarction in the distribution of the involved vessel. And the size, location, and shape of the infarct is determined by the duration of ischemia and the absence or presence of collateral blood flow. There is a network of blood vessels around the brain. Sometimes an occlusion in one supplying artery may be compensated by collateral flow. And if that collateral flow is adequate, it will limit the damage that is caused by that. Also, the duration of ischemia is important. If the clot dissolves before it causes severe damage, it may end up with only a small area of damage. Of course, the collateral flow can happen at the level of the circle of Willis, at the base of the brain, or the cortical leptomeningeal anastomosis. There is little collateral flow in the deep structures. That's why these structures are supplied by penetrating vessels, and we will see their appearance. In particular, the thalamus and the basal ganglia, the infarction in these structures happens immediately, and it does not allow time for collateral flow to compensate. Sometimes The vascular occlusion can be associated with propagation of the thrombus and increase in the size. As we can see here, the atherosclerosis inside the blood vessel or a blood clot that have traveled from somewhere else will cause occlusion of the blood vessel, and that occlusion, we have here the example of the middle cerebral artery, will cause the area that is supplied by the artery to be infarcted and to die. What are the risk factors of stroke? There are some non-modifiable risk factors. We cannot do anything about it. Age is important. The risk doubles for each decade after 55 years. We can't do anything about age. Every one of us will be aging. The gender, males are more affected by stroke than females. We can't do anything about that, although some people may think that they can change their gender. Race and ethnicity, the African ethnicity is more prone to develop a stroke, and we cannot do anything about the race. And family factors, nobody selects his family. However, there are significant amount of modifiable risk factors. The most important of them is hypertension. Cessation of smoking can reduce the risk of stroke. Improving the weight and body mass index can improve the risk of stroke. Cardiac factors, the most important is the presence of atrial fibrillation. Infective endocarditis, fortunately, is not very common, and the occlusion by clot that is happening from a recent MRI. And carotid stenosis, these all are modifiable. Transient ischemic attack is a warning and can be treated by preventive measures that we'll be talking about. Oral contraceptives can induce hypercoagulable state and sickle cell disease. We can stop contraceptives. We can try to reduce the viscosity of the blood that happens in sickle cell disease. Potentially modifiable risk factors are diabetes and hyperhomocystinemia. Now, after a transient ischemic attack, what is the risk of stroke? Researchers have come up with the so-called score of ABCD2. ABCD2 comes from A, B, C, and D. The A is for age. If the age is over 60 years, we give it 1. If the blood pressure systolic is over 140 or the diastolic of over 90, we give it 1. If the clinical symptoms is just unilateral weakness, we give it 1. If it is speech disturbance, we give it 2. Duration over 60 minutes, we give 1. And diabetes, we give it 1. And then we calculate how many points that we got. And if the score is 0, the risk at 3 months percentage is 0. If the patient has all of these factors, then score is 7, and the risk within 3 months, there is 22% of a stroke happening after a TIA. Focal ischemic stroke, as I mentioned, it's thrombotic, large vessel thrombosis, either extracranial or intracranial. Carotid bifurcation occlusion is similar to middle cerebral artery occlusion because it's the major contributor to the middle cerebral artery. It's frequently associated with hypertension, diabetes, and hyperlipidemia, which we call a metabolic syndrome. Hypercoagulable disorders such as sickle cell, such as malignancy, and so on. Antiphospholipid syndrome. Vasculitis is inflammation of the walls of the blood vessel, and it may predispose to thrombosis, like polyarteritis nodosa, Wegener granulomatosis, giant cell arteritis, which was called in the past temporal arteritis, and so on, or infections that cause inflammation around the blood vessels in the subarachnoid spaces and cause occlusion, and others such as dissecting aneurysm in the extracranial arteries or in the neck vessels that supply the brain, and drug abuse that affect the blood vessel by constriction, such as amphetamine, heroin, cocaine, and GAT, which is commonly abused in Yemen. Focal cerebral ischemia, embolic, the most common site is middle cerebral artery. It can be cardiac mural thrombus that happens in myocardial infarction, or decreased contractility of the heart after damage with myocardial infarction. Valvular disease, which either mitral stenosis or mitral regurgitation, which predispose to atrial fibrillation and formation of clot within the atrium. There is another form of embolism, it's artery to artery. That means that a clot will form in the artery, either in the aorta or in the carotid artery at the bifurcation, and then it will be dislodged from the area that it formed by the bloodstream and travel distally to occlude one of the blood vessels. There are other forms of emboli, such as what happens with patent foramen ovale. Foramen ovale is a hole in the atrial membrane, and it causes blood clots that may come from the periphery, from a blood clot in the legs, in the veins of the leg, and it comes into venous circulation. However, because of the hole in the wall of the atria, which is the patent foramen ovale, it may go from the right side of the heart to the left side of the heart and go into the arterial circulation. And this usually happens when there is a rise in the intrathoracic pressure, such as straining or coughing and so on. It would lodge at the vessel branching or in an area of stenosis. When a clot, an embolus travels, of course, as long as the size of the artery is smaller than is larger than the clot, it continues traveling until it comes to an area of stenosis where the lumen is narrower than the size of the clot, or when there is bifurcation. As we know, the smaller vessels come at the bifurcation. Now, there is in the middle and anterior cerebral arteries, there are several forms of occlusion. Now, if the occlusion happens in the stem of the middle cerebral artery, this is the carotid here, and this is the anterior cerebral artery, and this is the first part of the middle cerebral artery. If the clot happens here, this is the infarction that happens. This is on the lateral side, and this is on the coronal section. If the clot happened to dissolve on the side, but it's still hanging in the origin of the penetrating vessels, it will occlude the penetrating vessels which supply the basal ganglia and cause what we call a large vacuum. If it travels to the bifurcation of the middle cerebral artery, it will cause a smaller infarct. If it travels to the superior part of the branching, it will cause infarction of the upper part of the frontal lobe. If it goes to the lower branch, it will go to the temporal part and cause the infarction here. Now, if the infarction goes into the anterior cerebral artery, it will cause mesial cerebral infarction. Now, there is another form of infarction which is called the watershed or border zone. Watershed or border zone is a wedge-shaped type of infarction, as we can see here. And the reason for that is that this area is supplied by terminal branches of the middle cerebral artery, and it also gets supply from the terminal branches of the anterior cerebral artery. So it's dependent on both arteries. So it's supplied by small vessels that, although they anastomose over here, but if we have a situation where there is a drop in blood pressure, then this area is the first to suffer from lack of circulation. And in that case, we get what is called the pseudolaminar necrosis. Pseudolaminar necrosis is the involvement of the very vulnerable level of the, or layer of the cortex, which is usually the large cell layer because its metabolic demands is high. And we can see it grossly as a small line inside the cortex. And we can see it in the histological sections. And we can see that there are several cells that die in the pseudolaminar necrosis. Early in the infarction, we may not see evidence of infarction on the CT scan, or it may be not very visible, but there is a technique by the MRI called diffusion weighted image that will characterize the area of infarction. The gross appearance during the early infarction, the brain becomes swollen with wide gyri and narrow sulci, which means what we call it effacement of the sulci. In histopathology, in the early hours, we can see some ischemic neurons that change their color to red on hematoxylin eosin, like we can see here. And then in the subacute changes from 24 hours to 2 weeks, there is necrosis, and the body tries to clean up the mess. Then there is influx of neutrophils followed by macrophages, and some reactive gliosis starts happening. Then in the late stage, it's the stage of repair, which is cleanup and removal of the necrotic tissue. And then we get some, instead of having a scar, we have what we call gliosis in the central nervous system. Hypertension is, as I mentioned, important in causing cerebrovascular disease because it is associated with accelerated atherosclerosis, and it causes small vessel disease. Small vessel disease is the cause of lacunar infarction, and it is the cause as well of intracerebral hemorrhage, as we are going to see later on. Sometimes acute hypertension may lead to what we call hypertensive encephalopathy, where there is loss of autoregulation, there is dilatation of the blood vessels, and there is leakage of the plasma from the blood vessels into the brain. Hypertension, atherosclerosis, and diabetes, they are frequently comorbid conditions in the metabolic syndrome. So lacunar strokes are small. They are called lacunar because on brain cutting, we see them as a small fluid-filled areas that people thought that they look like a small lake. Another form of hypertensive lesions is, of course, 20% of all strokes are lacunar. They either affect the posterior fossa or affect the basal ganglia and the internal capsule and cause hemiplegia. The pathology is the blood vessels become lipohyalinosed, and there are microatheromas within these vessels. Remember, these vessels are small, 1 or 2 millimeter in diameter, so a small atheroma will cause them to close off. Small single multiple infarct is called a lacune, and clinically manifested as a lacunar syndrome, which is hemiplegia or dysarthria and so on, pure motor sensory stroke, ataxia, sudden clumsy head syndrome. All of these are typical lacunar strokes that were described over 50 years ago by a neurologist called Miller-Fisher. Some lacunar infarctions are without any symptoms. Now, this is the slit hemorrhages in the external part of the basal ganglia. Also, hypertension causes the small caliber penetrating blood vessels to bleed and cause small hemorrhages. Now, that leads us to talk about the hemorrhagic stroke. And hemorrhagic stroke, the gross appearance is that of brain parenchyma filled with blood. As we can see here, sometimes the blood is like petechial hemorrhages, and sometimes the blood is a gross hemorrhage with atrophy later on. So non-hemorrhagic infarcts versus hemorrhagic infarcts in appearance. The non-hemorrhagic infarct, we call it a pale or bland infarct associated with thrombosis and can be treated with thrombolytic therapy, especially if we can identify it early. While the red infarction, typically it is embolic, because the embolus, we can think of it like a throwing chips of ice in a warm stream. What happens to these chips of ice? They are going to dissolve. They will remain in their solid state for a while, and then they will dissolve. So similarly, the clots in the circulation will be attacked by the thrombolytic activity, the natural thrombolytic activity in the blood, and it will cause thrombolysis, or by intervention on thrombolysis. Then what happens if there is a branch of an artery that got occluded and then opened? It will reperfuse the area. It will reperfuse an area that had already suffered some partial damage, especially to its endothelium. The endothelium cannot take the stress of blood pressure inside, and or the reperfusion can happen through the collaterals from the leptomeningeal vessels or by dissolution of emboli, and then it will cause bleeding. Sometimes that happens when we, as a treatment, apply thrombolytic treatment, and the clot get dissolved, and then there is some focal hemorrhage. Now, venous infarction is often hemorrhagic. It is different than arterial because it is not ischemic. It is it is caused by the blockage of the outflow of blood from the brain. And usually there is thrombotic occlusion of the sinuses that drain the brain, and that's why we get bilateral congestion, and it will impede the further supply because it will cause a pressure inside the veins, and it will impede the circulation from the arteries. And the predisposing factor to venous infarction, it's either an occlusion of the blood vessel of the venous circulation that is non-septic, and non-septic means not associated with inflammation, and that it may be caused by dehydration or disease that leads to hypercoagulable states such as carcinoma, or if it is septic occlusion, it is related to spread of infection from an adjacent foci. The most common of that is inflammation in the middle ear, and that is in a close proximity to the lateral sinus, and can cause thrombosis in the lateral and sigmoid sinus. Now, how do we manage a stroke? Management related to 4 steps. Number 1 is to diagnose. Number 2 is to give supportive care. Number 3, to give acute treatment. Number 4 is to give complications treatment. And number 5 is to secondary prevent any other stroke. This usually is circulated to the public, and it helps them recognize the stroke as they recognize myocardial infarction by chest pain. We tell them, remember the word fast. Fast means if there is unilateral weakness of the face that causes drooping of the side of the mouth, and we check if the arms are unilaterally weak. That means if one holds both arms out, one of them is weaker. Then we check the speech. If the speech is garbled or he cannot understand the speech, then time is very essential. The person who notices a victim of a stroke should go to the phone and call for help. In a typical acute ischemic stroke, time is brain. So 1 minute of ischemia causes the brain to lose 1.9 million neurons, 14 billion synapses, and 7.5 miles of myelinated fibers. Very large numbers. And within 10 hours, 1.2 billion neurons are lost. So how do we diagnose it? First, we should identify when is the time the last seen normal. And it may be that the person went to bed, and when they tried to wake him up, they found that he is hemiplegic. Then the last time he was seen normal is the night before, which has a bearing on how we treat the stroke. So then we look at the differential diagnosis of an ischemic stroke. Ischemic stroke is sudden onset, focal deficit in a patient who has risk factors. We do brain imaging, we do blood tests, necessary blood tests that are sugar, BUN, creatinine, electrolytes, and we do EKG because cardiac tests are important. And we try to check for troponin to make sure that the patient does not have associated myocardial infarction. Acute ischemic stroke, the deficit is either unilateral weakness, sensory, visual deficit, blindness, or hemianopsia or double vision. The speech is slurred, or he has language problems such as aphasia, which is damage to the speech center, or ataxia in posterior fossa lesions, or some cognitive impairment if it affects the temporal structures. So what parts are affected by the stroke? We can see here that the leg is represented here, the arm is represented here, the face is represented here. That's why usually the arm and the face are in close proximity, so they get involved together. If this is in the dominant hemisphere, then there is aphasia. There is a problem with reading over here, sight over here, with the hearing over here, and so on. So the somatotopic representation is important. The typical stroke syndrome is contralateral hemiplegia and hemiparesis with facial weakness, aphasia when there is dominant hemisphere involved, and weak limbs. At first, they are flaccid due to cerebral shock, and then with areflexia, and then reflexes start to increase. Headache is unusual unless the stroke is caused by dissection of the neck vessels. Consciousness is usually preserved unless the stroke is in the posterior fossa structures. And after a variable interval, usually for several days, the reflexes will return, and then they become hyperactive with a Babinski sign. There are assessment scales for the stroke because they are important in determining what treatment to give. The acute assessment is with the NIH stroke scale, and the outcome is determined by the modified Rankin scale. So the National Institute of Health Stroke Scale is a list of things that are related to gaze, to visual, to facial palsy, to motor symptoms, to in the arm, in the leg, and so on. It's self-explanatory, and each one is given a score. And the modified ranking scale is simpler if the person, after, let's say, a few months from the stroke, have no symptoms, then he got back to normality. If he dies, that's the modified ranking scale of 6. And in between, we have either no significant disability or slight disability, and so on. Differential diagnosis, conditions that mimics acute ischemic stroke is Bell's palsy, or Todd's paralysis, or hemorrhagic stroke, or subdural hematoma, and other conditions. Bell's palsy, or in Arabic, laqwa, and in colloquial Arabic, Abu Jay, it is manifested by weakness in the upper part of the face and lower part of the face. So there is smoothing out of the wrinkles over the forehead, while we have wrinkles here. And we have some drooping of the eyebrow. This eyebrow is lower than this eyebrow, which is lifted up. And there is drooping of the corner of the mouth. It is caused by inflammation of the facial nerve that has 3 branches: frontal branch, buccal branch, and mandibular branch. So the differential is that the face is involved in the upper and lower part. Todd's paralysis is a condition that happens after a focal stroke, after a focal convulsion, and it is related to exhaustion of the neurons over there, and it can involve speech, it can involve weakness on one side. There might be some hyperpolarization in the area of the seizure, and usually it resolves within 48 hours. Other conditions that may mimic acute ischemic stroke is hypoglycemia, and that's why in acute stroke we immediately check for the blood sugar, and if the patient is hypoglycemic, he needs to be treated accordingly. Metabolic conditions such as fever, hyponatremia, drugs, and so on. Hypertensive crisis may cause some fleeting type of neurological symptoms. They may be focal on one side, and then they may be turned to focal in other side. Complicated migraine, we talked about migraine in the last lecture, and some vasospasm may cause some ischemia, and psychogenic or hysterical type of unilateral weakness can be detected by examination. So what do we do once we diagnose the stroke and we remove the mimics of stroke? Then we give, like in every treatment in the emergency room, ABC: airway, breathing, circulation. This is the standard supportive general care. We treat fever, we treat hypertension if it is very high. We give IV fluids to prevent dehydration, and we treat the underlying disease. Acute treatment for the stroke require a brain imaging, and CT should be done in all cases. Why? Because we don't want to give thrombolysis in a case where there is bleeding, because we can cause that bleeding to worsen. So what we see, we may not see the infarction, or we may see the infarction and we see a hyperdense middle cerebral, indicating that there is occlusion of that. Now, there is the concept of the penumbra. A penumbra is defined as the functionally compromised but structurally intact structure, which is affected by ischemia. Where did they bring this word penumbra? They borrowed it from the geophysicists, where we know when there is an eclipse that there are 2 areas on the Earth. There is central area, which is called the umbra, which is total darkness, where the moon covers the whole ball of the sun. So it is total darkness. But surrounding that area, there is an area of penumbra, where there is only part of the sun is covered. So they borrowed that and they called the brain tissue that is at risk of infarction, but it is still salvageable. We call it the penumbra. And this is usually the target for acute stroke therapy. And to see that in pathology, we look at this thrombus here, and we can see the area of infarction up here, and this whitish stuff. This is the area that is infarcted, and we cannot do anything about it. And there is this gray area, which is the penumbra, that if we lyse this thrombus, we may restore blood supply and save that area. How do we do that? We do the diffusion weighted imaging, which shows us the area that has infarcted. And we do by CT scan a perfusion weighted image. And perfusion weighted image shows us the area that is suffering of lack of blood supply. Of course, over here, the red means that there is good blood supply. Over here, we don't have a good blood supply. And that is area that compromised more than the area that is damaged by diffusion weighted image. And the idea is to go to the clot and remove it. There are certain devices that can remove the clot. So what can be done? We can give intravenous TPA, or tissue plasminogen activator. The R is for recombinant tissue plasminogen activator. It requires a rapid and coordinated response, and it can be given in the first 3 hours of symptom onset, because that's the time where the tissue is still salvageable, and the expected response time is about 60 minutes from door to needle. Once the patient hits the emergency room, we should not delay him more than 60 minutes to the needle in his hand to receive the treatment. So the rapid identification, we have to do the quick evaluation. We decide if the last time that he was seen normal is less than 3 hours. Someone have seen him while he's leaving from his work to home, and he was normal. When he arrived home, he was hemiplegic. Well, then that is the time last seen normal. Then we should rush him to the CT scan, and it should be less than 25 minutes, door to CT scan, and CT to radiologist reading the report should be less than 20 minutes. And once we read the report and see that there is not much damage to the brain, usually we do either CT or CT angio associated with it to know where the occlusion. Then we give IV TPA within less than 15 minutes. It shouldn't be more than 1 hour. As we can see from these curves, we can see that the best treatment is early. The best outcome within 3 months is with early treatment. And the more we go, this is 60 minutes, 70 minutes, 80 minutes, up to 120 minutes, the best outcome percentage comes down until we get to the 150 minutes, where there is very little to help the patient by giving the IV TPA. So usually we infuse about 10% of the total dose. The total dose is 90. And then we admit the patient for observation in the ICU, and we observe his blood pressure, because we don't want his blood pressure to go high and to cause the area that was somewhat damaged and then reperfused to bleed. So we measure the blood pressure 15 minutes every 15 minutes for the first 2 hours, then every 30 minutes for 6 hours, then every 1 hour for 24 hours. And usually there is a stroke unit in hospitals where they are treated similar to the CCU. This is a brain CCU. There are various forms of stroke unit depending on the size of the hospital. There is the primary or acute stroke unit, which is supposed to be in the peripheral hospitals. There is the comprehensive stroke unit in the referral hospitals, where thrombectomy is available. In the primary, thrombolysis by IV TPA is available. Then there should be a rehabilitation stroke unit, and there is, in some places, they give a mobile stroke unit. A typical component of a stroke unit is a place for assessment and early management, and to correct all metabolic derangements and to give rehabilitation. Then, what are the neurologic complications that we need to address? Cerebral edema may happen, and for that, we elevate the head of the bed 20 to 30 degrees in order not to increase, in order to reduce the venous pressure as much as normal. And also, we should avoid pressure on the neck because it can compress the jugular vein. Sometimes, if they give the breathing mask, they may have a tight attachment to it in the neck and may compress the jugular vein and raise the venous pressure inside the brain. We should avoid hypoxia, giving the patient a nasal oxygen, and we should consider intubation if the patient is not breathing well or if he is not protecting his airway. And we shouldn't give the patient hypotonic solutions in order to avoid increasing the edema, and we avoid corticosteroids in the early treatment. We treat cerebral edema and increased intracranial pressure. We treat seizures if they happen, and we treat the hemorrhagic transformation if it happens. Then secondary prevention is important. Someone had developed a stroke. How do we protect him from further stroke? The risk of recurrent cardiovascular events is high. Both within 30 days, there is a risk for myocardial infarction and for recurrence of stroke. In 1 year, there is more risk for myocardial infarction. They go hand in hand, although the risk for stroke is higher. So there should be some protection from recurrence. So we talked about the risk factors. We should treat the risk factors, the modifiable ones, and we should also give something that prevents occlusion of the blood vessels, such as antiplatelet or anticoagulants. There are 3 antiplatelets that are available: aspirin, clopidogrel, which is called Plavix, and aspirin plus dipyridamole, which is rarely used. If there is cardioembolism and there is tendency to form clots within the heart, within the atria, then either we give vitamin K inhibitors and we maintain INR between 2 and 3. If the patient cannot take the vitamin K inhibitor or he is not reliable for follow-up, we can give the direct oral anticoagulants which fight factor antagonize factor 10, and most of these are the name ends with ban, such as rivaroxaban, apixaban, and so on. And it should not be used in the non-cardioembolic stroke. It is strictly for cardioembolic stroke. So anticoagulants is not recommended for acute ischemic stroke. Some people think, why don't we give heparin? It is not recommended. And it is not recommended in moderately severe stroke. And it is not recommended within 24 hours after receiving recombinant tissue plasminogen activator, and used only if hemorrhage had been excluded. So the contraindication for anticoagulants: if there is a large infarction, if there is arterial hypertension that is uncontrolled because it may cause intracerebral bleed, in advanced microvascular changes in the brain. Possible remaining indication for heparin treatment when we have cardioembolic stroke: from artificial valve, atrial fibrillation, myocardial infarction with mural thrombi or left atrial thrombosis. If there is symptomatic dissection of extracranial arteries, because in such case, the clots may separate from the mouth of the area of dissection and travel distally, or in the venous sinus thrombosis, or if the patient has coagulopathy, such as deficiency in protein C and protein S. Secondary prevention may include carotid endarterectomy when there is severe stenosis, 70 to 99%, but it has to be done only in a center that has low complication rate, less than 2%, and that is level A recommendation. Carotid endarterectomy may be indicated in patients with 50 to 70% stenosis, and also in patients who have, in centers who have low complication rate, and it is not recommended if the stenosis is less than 50%. Interventionally, we can do carotid angioplasty and stenting through a catheter. It may be indicated when surgical treatment is not possible because it is inaccessible, and may be indicated with restenosis after endarterectomy. Intracranial anastomosis was tried in the past, and it failed to give any improvement. Prognosis, it is the second leading cause of death, and about 1/3 of survivals will return to independent mobility, while 1/3 will continue to have serious disability. If the patient has deep coma and dense hemiplegia, that's a poor outcome. And recurrence of stroke is about 10% every year. But the patient also may die from cardiovascular disease such as MI. Vasculitis is an inflammatory process involving the blood vessels and may compromise the blood flow to the brain. There is infectious arteritis that happens with meningitis, with syphilis, with tuberculosis, and now it is most often caused by opportunistic infections such as aspergillosis or zoster and so on. There is the systemic vasculitis such as polyarteritis nodosa and giant cell arteritis. There is a special entity, which is the primary angiitis of the central nervous system, which involves small to medium vessel, size vessel of the brain. It causes chronic inflammation and multinuclear giant cells. Intracranial hemorrhage now. Non-traumatic intracranial hemorrhage in the brain parenchyma is often manifestation of an underlying cerebrovascular disease. There is an intraparenchymal hematoma, which is non-traumatic, small vessel disease fragility related to hypertension, the most common cause of parenchymal hemorrhage, and typically occurs in the basal ganglia or the thalamus. And vasculopathy, such as amyloid angiopathy, which we'll talk about. Cerebral aneurysm is the cause of subarachnoid hemorrhage. So perianeurysm causes subarachnoid hemorrhage. Mycotic aneurysm associated with bacterial endocarditis may cause hemorrhage as well. And there are microaneurysms of Charcot-Bouchard in hypertension that cause intracerebral hemorrhage. Vasculitis is immune-mediated, systemic lupus erythematosus, syphilis, and so on may cause intracranial hemorrhage. Hypertensive cerebrovascular disease. This is what happens with hypertensive cerebrovascular disease. There is arteriolar sclerosis, which is hyaline. Hyaline means that when we do the sections in pathology, we see an amorphous material, which they call it hyaline, and that leads to thrombosis. Hypertension can lead to accelerated atherosclerosis in the larger arteries, and hyaline arteriolar sclerosis in the smaller vessels, and sometimes there is frank necrosis of the arterioles. Chronic hypertension may be associated with microaneurysms that were described by two French pathologists called Charcot and Bouchard, which may be the site of rupture and intracerebral hemorrhage. Also can happen in the arteries that are less than 300 micron in the basal ganglia and so on. Location and the size of the bleed is determined, it can determine the clinical manifestation. Hypertensive cerebrovascular disease in the acute stage, there is hypertensive encephalopathy, sudden sustained rise in the diastolic blood pressure over 130 millimeter, and that increases the intracranial pressure, causing headache, confusion, vomiting, convulsions, and coma. Rapid reduction of intracranial pressure is essential in such acute case. In the chronic case, there is multi-infarct dementia, which is multiple infarcts that are causing interruption of the connections between the parts of the brain, cortex, thalamus, basal ganglia, and so on. And the patient may develop dementia and gait abnormalities and what we call pseudobulbar signs, which is weakness in the muscles that are supplied by the lower cranial nerves, but that weakness is an upper motor neuron weakness. These are the aneurysms of Charcot and Bouchard. This is a small blood vessel of the penetrating vessels that was subjected for a long time to hypertension. It causes disruption on the wall of this small arteriole, and then there is ballooning of the adventitia of that blood vessel, and it may have a clot inside of it that prevents rupture, or it may lead to rupture and intracerebral hemorrhage. So the pathogenesis is the explosive entry of blood inside the parenchyma and immediate cessation of neuronal function due to the accumulation of blood, and the expanding hemorrhage mass effect may further lead to progression of neurologic deficit, either by mass effect or by causing herniation. This is a small hemorrhagic stroke in the basal ganglia that did not develop into a larger one, and this is a hypertensive hemorrhage in the lenticulostriate area, which caused a large clot and caused death in this patient. These are large hypertensive hemorrhage. So intracerebral hemorrhage may also be due to vascular malformation or other causes, such as amyloid angiopathy, which we'll discuss one by one. Vascular malformation is a congenital anomaly. The blood vessels, the arteries and capillaries come into contact with each other without intervening capillaries. So the arteries lead to the veins, and that causes the veins to arterialize and the arteries to venolize, and then we have a high flow structure. Amyloid angiopathy is a disease that affects the medium and small caliber vessels and lead to deposit of amyloid peptide inside the walls of the vessel, causing fragility. It stains with Congo stain, which stains red, and it stains amyloid very well. That's why it is called Congophilic. And it may occur in the lobes, unlike the microaneurysm that happens in the basal ganglia. This leads to lobar hemorrhage. cocaine and amphetamine use and the others can cause bleeding anywhere. Amyloid angiopathy, as we can see here, it deposits in the walls and it can be detected by special stains. And on MRI, since it leads to leakage of blood and accumulation of hemosiderin inside, there is a special gradient echo sequence on MRI that will display that very well. And can detect that in vivo. It increases the risk of hemorrhage, which is usually lobar, as I mentioned, and it may lead also to microhemorrhages, and MRI is good for showing it. These are the different images in amyloid angiopathy, and as I mentioned, in T2 we can see them, and in the other techniques that we use, like gradient echo on MRI, and this is a large hemorrhage that is caused by cerebral amyloid. These are different cases that have the cerebral. Intracerebral hemorrhage, what is the goal of early management? Number one, like the ABC, we have to manage the airway, give adequate oxygenation, and to prevent aspiration, because patients with intracerebral hemorrhage frequently vomit. And since blood is irritant to the cortex, they may have seizures. So we give anti-epileptic drugs such as phenytoin or an equivalent to it, and we maintain them with the seizure prevention. Now, the goals of management is to keep the blood pressure about 160/90, or to keep the mean arterial pressure around 130. In the first 48 hours, if there is, we should not allow the blood pressure to drop more than 15 to 25% of the presenting value. Why? Because if the blood pressure stays up very high, there is very poor outcome, because the hematoma will enlarge and there is more damage to the brain structures. If the blood pressure if the blood pressure drops precipitously, then there is very poor outcome because of decreased perfusion of the compressed brain. Subdural hematoma is bleeding on the surface of the brain. The treatment is to correct coagulation and to monitor the neuroscience. Surgical management for it is to do a small hole in the cranium and to drain the blood, or to do craniotomy for removal of a solid clot. Subarachnoid hemorrhage is very important subject, and it is the most frequent spontaneous cause of rupture of the saccular, or what they call berry aneurysm, because it looks like a berry. The pathogenesis, either heritable disorder, such as polycystic kidney disease or collagenoses, or cigarette smoking, alcohol, and hypertension. Other causes is vascular malformation, can be associated with berry aneurysm. Early symptoms are those of headache, seizures, dozes, and the typical sign is to have neck stiffness. The onset is sudden onset, severe headache that the patient never experienced similar things before, nausea and vomiting. They may lose consciousness. They may have symptoms of meningeal irritation, which are photophobia, focal neurological deficit, sudden loss of consciousness, as I mentioned, and seizures. There might be mild to moderate blood pressure elevation, maybe tachycardia. Nuchal rigidity is very important to check for. Papilledema and retinal hemorrhage may happen and global or focal. These are the aneurysms. This is what they call the saccular aneurysm. And as we can see, the wall of the saccular aneurysm is manifested by loss of this elastica. And this elastica, as you can see, it is corrugated type. It's similar to the telephone cord that you that can be stretched. If it is lost, then we have no resistance, and the artery will be open to the pressure, and it will cause the artery to dilate and cause a perianeurysm that can be seen on angiography like this. And this is the subarachnoid hemorrhage, blood accumulating in the sylvian fissure. This is imaging 3D of the perianeurysm as we can see it here. The complications are rebleeding, vasospasm, hydrocephalus, seizures, and cardiac dysfunction. The management is by either clipping or coiling of endovascular. Vascular malformation as a source of hemorrhage are, as I mentioned, they can be congenital vascular malformation, and they grow as the patient grows older. It is males are involved more than females, and they can be seen on angiography like we see it here. And cavernoma is a special, not high flow, but it's a special form of cavernous angioma, and it is usually because of epilepsy, and its appearance is that of they call it a popcorn type of appearance on T2 weighted images. So in summary, TIA usually clears within 24 hours. Large vessel atherosclerosis causes non-hemorrhagic stroke. Embolic can be lead to hemorrhagic transformation. Hypertensive hemorrhage and or lacunes. Watershed infarct in hypotension and hypoxia. Venous thrombosis is rare and hemorrhagic, and vasospasm secondary to subarachnoid hemorrhage is an important part of morbidity. CT imaging may identify hemorrhage and lead to non-use of RTPA. Diffusion weighted image identify the non-hemorrhagic infarct early. Now we'll take about 5 minutes break, and we'll come back for we'll come back for talking about coma and disturbance of consciousness, which will take less time than the cerebrovascular disease.